along with Washington University and the Barnes-Jewish Hospital transplant programs. I'd like to welcome you to this evening's Lung Transplant Town Hall. My name is Greg Richardson. I'm the manager of the Heart and Lung Transplant programs here at Barnes-Jewish Hospital. Tonight, several of our transplant team members are here to answer your questions about the transplant process. And I'd like to start by giving each one of them a chance to introduce themselves. Excuse me. We'll start with our program medical director, Dr. Ramsey Hashem.
Thank you, Greg, and thank you all for joining this town hall. We're excited to put this on, and we hope to answer a lot of questions about lung transplantation for CF. And I want to thank the team for being here and really putting this together. They've done a terrific job, and we're all excited and looking forward to this town hall tonight.
And tonight we also have one of our nurse coordinators, Beth.
Hi, everyone. My name is Beth Albertine. I'm one of the nurse coordinators. I'm a pre-lung transplant coordinator, so when you want to come for an evaluation, you'd be assigned one of the nurses. There's a few nurse coordinators, and I'm one of them. And then we help you through the evaluation process and the listing process, as well as being on the transplant list. So thank you all for joining us tonight.
We also have our social worker, Rebecca.
Hi, everybody. I'm Rebecca Bathon. I am the social worker for the lung transplant program at Barnes-Jewish, and I follow patients both on the outpatient evaluative side as well as in the hospital, and we welcome you this evening.
And our dietitian, Kate.
Hi, everyone. I'm Kate Stockman. I'm the lung transplant dietitian with the team here. I work with your CF dietitian just to make sure that we optimize your nutritional status before transplant, and then you don't get rid of me. I follow you post-transplant, help keep you as healthy as possible for as long as possible.
Thanks, everyone. So tonight we hope to provide you with some basic information about the transplant process and our program's approach to caring for our transplant patients. We received some great questions prior to this evening's event, and I want to thank everybody who had an opportunity to submit a question in advance. I did, however, want to remind everyone that you do have the opportunity to submit questions throughout this evening's town hall event. So if you think of a question or something that we're talking about kind of prompts a question, please feel free to type it into the text box there and submit it. And then I'll remind you again at the end of this, but then also included there on the page where you have the option of submitting a question, there's a link to a survey. So we would appreciate it if you would take a minute at the end of this event to complete a pretty short survey, as your feedback is really important to us. So I think to start this evening off, Dr. Hashem is going to talk a little bit about our lung transplant program, specifically lung transplant for cystic fibrosis, and our program's relationship with the cystic fibrosis centers.
Thank you, Greg, and thanks again, everyone, for attending this town hall. Our lung transplant program has been in place since 1988. And we've had a fairly large and busy transplant program really from the inception of the program. We've worked closely with a lot of the CF programs in the region, particularly the CF centers that are represented in tonight's town hall. St. Louis University, being just about 2 miles away, has been very close geographically, and we've had very close relationships personally and professionally with the team there. And a similar close relationship with the University of Missouri and Columbia and University of Tennessee and Memphis Methodist Hospital. And that collaboration has really been very helpful for everyone involved, from the transplant center's perspective, the CF center's perspective, and most importantly from the patient's perspectives. Much of this collaboration has been driven by the CF Foundation and this initiative to improve the process of referral to lung transplantation, evaluation, the care of the patients during that time period, then listing for transplant, and long-term management. Obviously, there are differences from CF center to CF center and differences in terms of where a patient lives in relation to the transplant center and the CF center in terms of what aspect of the patient's care is received at which center. But our relationship has really been terrific with all of the CF centers, and that strong relationship, I think, translates into better patient care, better communication with the two centers, and most importantly, with our patients. 2020 has been a tumultuous year, to be sure, with COVID and the effect that that's had on everybody. Everyone's been affected by it all over the world, and so have we, and so have our patients. But in good news, late 2019 saw the beginning of the Trikafta era, and that has been a remarkable success story in the care of individuals with CF. And I think some of the questions are related to Trikafta and lung function and lung transplantation. So I'll wait to hear about those questions and give my perspectives. But this has been a really incredible year, and there have been a lot of changes in many ways. So I'll stop here for introductory remarks, and we can get started with the questions.
Thanks, Dr. Hashim. As I said, we received a number of questions in advance, and so what we did was we took those questions and kind of categorized them along the lines of the different phases of the transplant process that they pertain to. So we're going to kind of start the evening with questions related to pre-transplant or the referral process, and then questions about the evaluation phase of the process, and then being on the waiting list, and then finally post-transplant. But certainly the questions that come in live during the course of the evening's event, we'll just kind of take those as they come in, regardless of where they may happen to fall within the process. So we're going to start with a couple questions about the pre-transplant phase of things. And so a question, I think, for you, Dr. Hashim, and it's simply, what would qualify me as a candidate for a transplant evaluation?
It's a very good question, and this has changed in the last couple of years, in large part because of guidance from the CF Foundation, where the recommendation today is that individuals with CF have an evaluation for lung transplantation at an earlier stage of their lung disease than what was being done in previous years. In the past, the idea was to be referred for a lung transplant when the time was appropriate to have a lung transplant. But in many circumstances, there are factors that could be modified to make the recovery from the transplant smoother and shorter after that transplant hospitalization. So that an earlier referral to identify those factors where there may be an improvement in someone's health before transplantation to get them ready and prepared for transplant really facilitates the post-transplant recovery. And so the recommendation is now to be referred for a transplant evaluation early in the course of someone's lung disease, recognizing that it's not time to be listed or time to be transplanted. But it's an opportunity for the transplant center to meet the patient, meet the family, for the patient and the family to get to know the transplant center, learn more about what transplantation is about, what's expected afterwards, what are the medications, what are the routines that are necessary afterwards, and identify any potential factors that require some attention and modification before the transplant so that the recovery period is smoothest. As an example, someone might need to gain weight or someone might need to get in better physical condition before a transplant. There are also some financial and logistical issues that might need to be addressed ahead of time. And so it's best to address all of these at an early stage so that there's time to devote the necessary effort to address those issues before listing and ultimately transplantation.
All right, thank you, Dr. Hashim. So our next question pertaining to the pre-transplant phase is about exercise. And the question is, do I have to exercise if I want to get a transplant?
Yeah, the short answer is yes. And that's recommended for all patients who are being put on the waiting list for transplant. And in really very broad terms, the condition that one is in going into a transplant really determines the recovery period after the transplant. And we all want the recovery period to be as smooth as possible and the hospital stay after transplant to be as short and uncomplicated as possible. And in general, when patients are taken off of the ventilator immediately after transplant, this usually happens on day 1 or day 2 after the transplant. We try to get patients up out of bed, in a chair, walking, with multiple chest tubes and so on. So as you might imagine, the physical condition that somebody is in going into the transplant will really impact how that recovery period will go. The better shape one is in, the smoother that recovery will be, and the quicker the patient can walk and ambulate and so on. And that really facilitates all of the recovery factors after transplant. So yes, we ask patients to exercise, whether that's exercising at home, walking on a treadmill, or in a formal pulmonary rehab setting. But the goal of exercise is cardiovascular exercise rather than weightlifting. And the general recommendation is to walk on the treadmill continuously for 30 minutes.
All right, thank you. So we have a question that that just came in this evening, and I think it kind of fits with the discussions that we're having right now in terms of, the evaluation process and when would be the right time to be evaluated. And you touched on this a little bit in your opening remarks, and it has to do with Trikafta and some of the new medications that are available right now, and how that may potentially impact the future of transplantation for patients who have CF, since we're seeing such good results with that. And the person who wrote the question actually mentions that they were evaluated in March of 2019, started the medication last fall, gained 10% lung function and 40 pounds. So first of all, congratulations to you. That's great. But Dr. Hashem, what are your thoughts about the future?
Yeah, as you just said, Greg, I would congratulate the patient on the results of being on Trikafta. And in truth, that's generally what we're seeing. And by we, I mean at Barnes-Jewish Hospital's lung transplant program, but also across the country, that Trikafta has really had a tremendous impact on lung function and weight. And a number of patients who were flirting with the idea of being listed for transplant had a significant improvement in lung function and weight gain and decrease in exacerbations, where it became very obvious that transplant was unnecessary. Now, initially, there was some concern about how long-lasting these benefits with Trikafta would be, but many of the patients who were started on Trikafta last fall have had lasting results throughout 2020 and into the latter part of the year so far. So I think the expectation is that we're going to see these results be lasting results for years to come. And on an individual basis, I think that's terrific news for patients who've seen this improvement with Trikafta. And what's likely to happen is that over time, there will be a decline in lung function again, but that decline in lung function is likely to be much slower than it had been before the patient was started on Trikafta. Now, across the country, the number of transplants for patients with cystic fibrosis in 2020 decreased compared to previous years. And in large part, that decrease is because of Trikafta and stories, as I just shared, of patients who were about to be listed, no longer needing to be listed, and obviously no longer having a transplant. But the CF Foundation has made some calculations and projections about the potential need for transplant over the next 5, 10, and 20 years. And based on aggregate data of patients' lung function, the expectation is that in the next 10 to 15 years, we will still need to do a lot of transplants for individuals with CF. Keep in mind also that there are some individuals with CF who do not have a mutation that would benefit from Trikafta. And for those individuals, obviously the benefits of Trikafta are not going to be seen. But the CF Foundation expects that lung transplantation will remain an important treatment in the care of patients with CF.
All right, thanks, Dr. Hashem. So our next series of questions really focus on the evaluation phase of the transplant process. And the first question here is one that I think would be perfect for you, Beth. And the question is, how do I get referred for a transplant evaluation?
Yeah, so the best way to be referred for a transplant evaluation is to have your CF doctor send the referral over to our transplant center. So I would encourage you all to talk to your physicians or nurse or whoever you would like at your CF center. Let them know you want to be referred for transplant, and your doctor can then send over your records to our office to be considered for a transplant evaluation. Once our office receives those records, one of the nurses will review your records, and we'll go over those with one of our physicians, and we'll make a decision on whether or not we will bring you in for an evaluation. And then we would be in contact with you to schedule that.
So Beth, our next question is really just about the evaluation itself. And the question is, what does a transplant evaluation consist of?
Yes, so the transplant evaluation is actually 4 days of outpatient testing in St. Louis. So you would need to travel to St. Louis, and when you travel, it usually takes a little closer to 5 days. So I usually tell patients to plan for that. And our evaluations always start on Monday mornings. And we'll put you through a variety of testing. Some testing you've probably already had at your CF center, such as, we'll do blood work, a chest x-ray, a pulmonary function test. We'll do a 6-minute walk. We'll also do a chest CT scan because we'll want to get some imaging on, what your chest cavity and your lungs look like. And then we'll also do some testing to look at your heart as well. The testing is usually all day Monday and Tuesday morning, and then on Tuesday afternoon, you'll be able to meet with one of our lung transplant pulmonologists. And that's a really good time for you and your family to talk with the doctor about lung transplant and how lung transplant affects you as an individual. And we decide at that point whether or not we feel it's a good time for a transplant for you, or maybe you're early for transplant. So there's a lot of different options. As Dr. Hashem mentioned earlier, we like to see patients early in the process. We like to get to know you, and then you can get to know our team as well. So sometimes we do send you home early. But if we do decide to move forward, sometimes we do some heart testing on Wednesday. Sometimes that is a heart catheterization. Other times it may just be an echocardiogram. And then on Thursday, you meet with everyone else on our team. As you can see, Rebecca and Kate are here with us this evening. So you would get a chance to meet with them, as well as our financial coordinator. Then at the end of the day, Thursday, we have an answer for you, whether or not you're a candidate for a transplant. So even though it's a long 4 days of testing, you have a really good answer and understanding about where you stand within the transplant process. So you're not on the transplant list at that point, but you're just coming here to get all the information and meet our team. So that's pretty much the whole transplant evaluation. It's a busy 4 days, but like I said, it's worth it. And it's all done in 4 days.
Thanks, Beth. The next question is one that perhaps you and Rebecca would both like to comment on. And the question is, what can I do as a patient to prepare for the evaluation?
Rebecca, I'll let you start.
So I think the message that we really want to relay to people considering coming for an evaluation is to not feel that there are a lot of barriers. We want to try to address as much as we can so that you can come and see us, whether that is your medical records, whether that is finances, whether that is caregiver support, or just traveling to get here. We have a lot of resources. So I think the most key piece is identifying somebody within your family or network of friends that can come with you. The caregiver is really an important piece of this, but the message that we hear from other transplant programs is that we are the ones that want to do the education. We are the ones that want to tell you more about how everything works. So come and talk to us about that and where you stand. Anything you want to add, Beth?
Yeah, so as Rebecca mentioned, the transplant evaluation, we always encourage, and it's also required for patients to bring one caregiver with them or a support person. So sometimes that's a family member, a friend, somebody who's going to help you through this process. So that would be a requirement of something to prepare for. And like Rebecca said, we really want you just to come here, and we like to get to know you, and you should get to know us as a team because we'll be caring for you. And use your transplant coordinator. We're here to help you. We want to bring you here for an evaluation, and lean on them and let them know, like Rebecca said, if you're having any concerns or anything, and hopefully we can try to help you out and get you here and see if you're a candidate for a transplant.
Well, thank you both. Our final question pertaining to the evaluation phase of things is one perhaps for Dr. Hashem. And the question is asking, does the evaluation have to take place in St. Louis, or can I have some of this testing done closer to home?
Generally, the evaluation is done at Barnes-Jewish Hospital. Obviously, the biggest part of the evaluation is meeting the team, and so we would want to meet you and have the conversations about what transplantation is, what are the pros and cons and potential problems and expected outcomes and so on, and answer any questions that one might have in person, and that's the best way of doing it. In terms of the testing, updating the testing that has been done previously is also important to have a trajectory of where someone's lung disease is going and the rate that the lung disease may be changing over time. Now, if someone has recently had tests for other reasons that would be part of the evaluation, I think sometimes those are okay and those are acceptable to just say, we'll just use the CAT scan that was done 2 weeks ago at the local hospital instead of repeating a CAT scan. But generally, we do all of the evaluation and the testing that goes along with the evaluation at Barnes-Jewish Hospital.
Thanks, Dr. Hashem. The next series of questions talks about kind of being on the waiting list and the waiting period itself. And we received a couple questions about just how donors are allocated. So perhaps you, or if Beth would like to weigh in on this, we could just talk a little bit about the process of donor allocation at the time of transplant.
Yeah, that's a very good question. The system that governs donor allocation is a national system, so it isn't something that's unique to Barnes-Jewish Hospital or St. Louis or our region. It's a national system, and it's called the lung allocation system and the lung allocation score. The purpose of the lung allocation score is to maximize transplant benefit, and this score is meant to reflect the urgency for a transplant or the need for a transplant, as well as the likelihood of surviving the first year after transplant. And incorporating both of those factors into the lung allocation score maximizes the benefit of transplantation, or the predicted benefit of transplantation. The factors that go into the lung allocation score are all objective factors, like the underlying diagnosis, CF for individuals with CF, as opposed to other diagnoses, lung function test results, the need for supplemental oxygen, some blood test results, some test results from a heart catheterization or an echocardiogram. And those factors go into this national calculator that generates a lung allocation score. The score ranges from 0 to 100. The higher the score, the higher the urgency for transplantation. And this is, in some ways, a double-edged sword. On the one hand, everyone wants to have their transplant and be done with it. And so you may want a high score, but what that really means is that you're really sick and really need a transplant. And so I'm not sure that if I was a patient, that I would want a high lung allocation score. I would want to have a transplant, but maybe not be so sick that I have a high score. And although the scores range from 0 to 100, they tend to be clustered together between the low 30 range to the mid to high 40 range. As you might imagine, most individuals waiting for a lung transplant are in the same category in terms of urgency for transplant. That everybody needs a transplant. That's why they're on the waiting list. And so small changes in the score really differentiate one person from another. There are other factors that determine who gets the next set of lungs, if you will, once you're on the waiting list, other than the lung allocation score. Blood type is one of them, and body size is another key factor. As you might imagine, a donor who is 6'5" couldn't donate lungs to a recipient who is 5 feet tall, and vice versa. So size factors into who has the next set of lungs. Beth, is there anything that I've missed?
I think you covered most of it. The only thing I would add is once you are on the transplant list, we follow you very closely as a transplant team. You are required to come here, come back to our center anywhere from 4 weeks to 8 weeks that we like to see you, depending on how you're doing, how sick you are. And during those visits, we update your testing. So we're going to be watching your lung function, how much oxygen you need, and we will update your lung allocation score based off of that testing. So it will reflect your current status. So if you're getting sicker, your score should hopefully reflect that and hopefully make you a higher priority on the wait list.
All right, thank you guys. So, on the topic of waiting for the transplant, Dr. Hashem, would you like to talk a little bit about what the average wait time is for transplant? That's one of the questions we received here this evening as well.
Yeah, that's a very good question. In the past, and this is maybe ancient history by lung transplant standards, before 2005, the waiting time used to be about 2.5 years, which is a very long time. And that matters in terms of listing people for transplant, especially if one was going to wait 2.5 years. That's no longer the case, in large part because of the change in the allocation system, where the lung allocation score determines or is the primary determinant of who has the next transplant. So currently, the average waiting time at our hospital is 2 months. Nationally, the average waiting time is about 3 months. And so the waiting time is generally fairly short. And what that means is that people that are on the waiting list for transplant are really going to have a transplant pretty soon. That average is only that. It's 2 months for the average. And in many cases, it's much shorter than that. It may be as short as a day or two in the case of someone who's in the hospital on a lot of oxygen and is very sick. But in other circumstances, if there are some extenuating circumstances, most commonly having HLA antibodies that narrow the donor pool or the potential donor pool, the waiting time might be longer than that. It may be months, 6 months, a year. In rare circumstances, more than a year. Again, the most likely reason that someone might have to wait that long is having these HLA antibodies that narrow the potential donor pool, where so many donors just would not work out for that individual recipient. But again, the message is that the waiting time on the waiting list is on average about 2 months.
Thanks, Dr. Hashem. Beth had mentioned that, when patients are on the waiting list, we follow them closely to monitor them for changes in their condition that could affect their LAS. But our next question is really about patients who are not immediately listed. And so the question is, what about patients who are not immediately listed following their evaluation? How is their follow-up and eventual listing managed?
That's a very good question. And the way to work this out is really an individualized plan at the end of the evaluation. And it's individualized based on the patient's needs and the expectation for what's likely to happen in the next 3 months or 6 months or 12 months. For example, if we're seeing someone early and everybody recognizes that it's early in the course of their lung disease and that transplantation is not necessary right now, but we'd like to meet the patient would like to meet us, learn about transplantation, et cetera. Obviously, at the end of that evaluation, we're not likely to have the patient come back in the next 2 to 3 months. We're likely to say, come back in a year. Obviously, if things change, if the course of your disease is becoming more aggressive, you're having frequent exacerbations, hospitalizations, lung function is declining, we're going to have you come back sooner, or your CF team is going to call and say, hey, look, the patient's not doing well, we need to see them sooner. On the other hand, someone who is closer to needing a transplant, but not quite ready to be listed for a transplant, we'll work out a follow-up plan that's appropriate in terms of having them come back maybe in 6 months or 4 months or 3 months, depending on what seems to be the most appropriate time to come back. Obviously, we'll work closely with the CF team about having them come back, depending on what's happened in that interim. For example, if somebody leaves the evaluation with the plan to come back in 6 months, but they get hospitalized once or twice with an exacerbation, we need to change that follow-up plan and have them come back sooner than 6 months, because maybe the initial impression was that they needed a transplant maybe in 6 months or a year, and that may no longer be the case, and we need to revisit that timeline.
Thanks, Dr. Hashem. Our next question is one for Kate, and the question is, will I need to make any changes to my diet as I wait for a transplant?
While you're waiting for the transplant, no, you don't need to make any changes unless there's very specific things that we need to hone in on. If you need additional protein or if you need to gain weight or lose weight, it's very specific and very individualized. So while you're waiting for transplant, there's really nothing that we need to significantly change unless there's something that needing to be somewhat fixed or managed. But post-transplant, there are some things that we do ask you to change, which I think we'll eventually get to those. But as far as pre-transplant, as long as you're getting adequate vitamins, adequate minerals, taking your ADEX like you're supposed to, and then making sure that you're getting adequate calories and protein, typically things are going okay.
Thanks, Kate. And our final question regarding the wait list period ties in the COVID pandemic. And the question is, how are you handling COVID in the transplant process when it comes to getting the call? With not allowing the usual number of visitors, what's the best way for the support teams to wait as the surgery happens?
That's a very good question. First, let me clarify how we select donors and test donors and test recipients as well. And then I'll talk about the visitor policy. All donors really since probably late March of 2020 have been tested for COVID, with the idea that it's possible that someone might die of something completely unrelated, but if there's a lot of COVID in the community, it's possible that that donor has COVID and they die of a car accident or a stroke or some unrelated problem. We wouldn't want to use lungs from someone who has COVID at the time. So all of the donors are tested for COVID before they're accepted for transplant. The recipients are also tested for COVID at the time of their transplant, because we wouldn't want to transplant someone while they have COVID. And that would potentially cause very serious problems in the transplanted lungs. So if someone's on the waiting list for transplant and they develop COVID, we would hold off on doing the transplant until they've recovered from COVID. But oftentimes the symptoms can be really confusing. It can be very similar to baseline symptoms that someone who has severe lung disease might have: cough, shortness of breath, congestion, wheezing, etc. Difficulty with sense of taste and smell. And so all the recipients are tested at the time of transplant, before the transplant, the day of the transplant, to make sure that they don't have COVID as well. Now, in terms of the visitor policy, I'm sure that everybody is aware that most hospitals have restricted their visiting policies. currently the policy is that there can only be one visitor at a time, even if it's for someone who's having a transplant. Unfortunately, earlier in the pandemic, the policy was even more restrictive, where patients really could not have any visitors. So it's a little bit better currently in that there's at least one visitor that can come, but no more than one visitor.
Thanks, Dr. Hashem. So our next series of questions focus on the post-transplant period. And the first couple are questions that perhaps you would like to address, Dr. Hashem. The first being, how long is the average hospital stay post-transplant?
The average length of stay in the hospital is about 3 weeks. In some circumstances, things sail beautifully and patients recover very quickly, and everything goes very smoothly, and they may go home in under 10 days, maybe 8 or 9 days. But on average, the stay is about 3 weeks.
All right, and the next question we have for you is about medications. And the question is, what type of medications will I take after a transplant?
There's a number of medications, as everyone might imagine. The core group of medicines are the anti-rejection medications or immune suppression medications. There are 3 of those, and 2 of those medications are taken twice a day, and 1 is once a day. One of those is prednisone. The other 2 are mycophenolate mofetil and tacrolimus. Then there are medications to prevent infections, and those are generally taken every other day or 3 times a week. There are medications to prevent viral infections that are once or twice a day. And then there are some other medications to treat other potential side effects of the anti-rejection medications. For example, if someone develops high blood pressure, they need a medicine to treat the blood pressure. If they develop diabetes, they need a medicine to take care of diabetes. In CF-related diabetes, the only medicine that's recommended is insulin. Obviously, the other treatments that an individual with CF that used to take before transplant, some of them are continued while others are stopped. The medicines for the lung disease are generally stopped. So nebulized pulmozyme, hypertonic saline, albuterol, nebulized tobramycin or colistin, those are stopped after the transplant, whereas pancreatic enzymes are continued. Insulin for diabetes is continued. And so it's a lot of medicines that one has to take, and in many ways it's changing the regimen that patients used to take before transplant to the post-transplant regimen.
All right, our next question is one for Kate, and the question is, after transplant, what foods do I need to avoid?
So this is where there are some adjustments that might need to be made. So again, the diet recommendations are going to be very specific to each person, but there are some overarching things that we do ask you to avoid long-term while you're on immune suppressing medications. So some of the big take homes are grapefruit or grapefruit juice. We also add pomegranate and starfruit. Those directly interact with your post-transplant medications. So those are ones that we do ask you to avoid long-term. The other things that we ask you to either modify or to remove include like raw or rare undercooked fish or your proteins like red meat. So no more rare steak, unfortunately. It does not have to be a hockey puck by any means, but it just does need to be cooked fairly well. And we give you a handout before you leave the hospital that gives you all of the temperatures that we recommend for your meat products. That way it's more of a very medium well done, but it's still fully cooked so that all the bacteria could be cooked out. But also things like sushi, we teach you to avoid any raw fish or things like that. When it comes to your egg products, again, we do want them cooked well, but it doesn't have to be an over hard yolk. It can be a softer yolk. It just needs to be a pudding texture where we know that everything has been cooked well enough. No unpasteurized milks or juices, and we're getting to that time of the year where apple cider tends to be very common. So we do ask you to make sure that that is a pasteurized product. Also bean sprouts. So those are grown in a moldy environment. So we do ask you to avoid those. They are very small and have a hair-like texture and can be very difficult to clean well. So we do ask you to avoid those. Jimmy John's used to put them on their sandwiches a long time ago, but there were quite a few salmonella outbreaks, so they also don't even put them on their sandwiches anymore. So most of the time it can be hard to find them in most of your food products anyways, but just something to be on the lookout for. We also ask you not to do kind of the smell test anymore, so you don't sniff food to make sure that it smells okay and then eat it. If it's been a couple of days in the fridge, or if it's past its sell-by date or past its use-by date, just either have somebody else in your family go for it or just go ahead and pitch it. All the other things are really just food safety. So cooking your food well, washing your hands before you make any food and after, using separate cutting boards for cutting your meat products versus your produce, just things like that. And then also heating up any kind of leftovers, cold cuts, things like that. But like I said, the education is always provided after transplant. We make so that we can answer any questions and just clear up any anything that needs to be clarified prior to you going home.
Thanks, Kate. I think I'm the person in our house who is the one who's asked to go for it and gets asked, hey, taste this and tell me if you think it's all right. So I wouldn't volunteer for that. So Dr. Hashim, our next couple questions are about activity post-transplant. And the first one is, after transplant, am I limited in activities that I can do?
Very early after the transplant, in the first month or 6 weeks or so, we ask people not to lift objects that are more than 10 pounds in weight, mainly because the incision is still healing and the ribs that have been separated are sort of put back together. And so we don't want anything to sort of come apart or dehiss the incision by lifting some heavy object. But really beyond that first 4 to 6 weeks, there really aren't any activity restrictions. People can exercise regularly with cardiovascular exercise, swim, bike, run, lift weights. All of those activities are perfectly fine.
Okay, our next question is along those same lines, and the question is, after transplant, will I still be considered disabled because of my lung disease?
Rebecca, would you like to weigh in on this?
I'd be happy to. You know, this is a difficult question for people to realize, but typically our program follows the practice that about 6 months after a transplant, most of our patients can go back to work, meaning resuming a job that they've done in the past, considering there aren't limitations because of the transplant or being immunosuppressed, but also many of you being young people thinking about your career goals and what those next steps are to earn gainful employment. So ticket to work, vocational rehabilitation, finishing a college degree, getting a GED are all key steps in aging and becoming adults and moving on with life. Technically, if you are on Social Security disability at the time of your transplant, Social Security will let you remain on those benefits for 3 years. So we do talk about what that plan is going to look like for you and what your interests are, what is safe for you to do, and what is a position or a job that's going to help you support yourself and your family, and as well as maintain insurance that's going to cover your medical care.
Thanks, Rebecca. So our next question is one for you, Dr. Hashim, and it has to do with post-transplant pregnancies. And the question asks, is it safe to become pregnant after transplant?
That's a very good question, and it comes up not infrequently in our clinic. We've had a number of women with CF who've become pregnant after transplant and delivered a baby. The CF Foundation has a set of consensus statements about the care of individuals with CF after lung transplantation that will be coming up or coming out in the next 6 months or so. And pregnancy is one of the areas that was addressed by these consensus statements. And so the working group that addressed these questions, and pregnancy in particular, reviewed the literature that's been published about pregnancy after transplantation and lung transplantation in particular, and pregnancy in women who have CF. And what we were able to find is that pregnancy beyond 2 years after the transplant outcomes were better than when pregnancy happened within the first 2 years of transplant. That 2-year period seems to be really important in the sense that we have a good sense of how the lung function is, and patients have become accustomed to their immunosuppression, and we're on a steady level of immunosuppression. In some ways, we're out of that early window where infections are more common and potentially more problematic. And so the recommendation is to wait at least 2 years after transplant before becoming pregnant. But recognize that there are some potential problems related to pregnancy after transplantation. And these problems relate to the baby. Prematurity is more likely in a woman who's had a transplant. Preterm birth is more likely. There are some medications that are associated with birth defects, and those can be adjusted. There are alternatives to the medicines that are most associated with birth defects. But in spite of making those adjustments, there is a higher risk of birth defects with the anti-rejection medications. There's a risk of rejection and accelerated rejection in the mother that can happen with pregnancy and in that first month or so after delivery. And so unfortunately that has happened as well. And then there are issues pertaining to longevity of the mother in the context of a life of a baby who is going to grow to be an adult at the age of 18, 19, or 20. So all of those are very difficult questions, but we've worked through them with women and their families. It's important to involve experienced obstetricians and specialists in maternal fetal medicine at an early stage in planning pregnancy and in managing the pregnancy. And so it's something that I think is best handled openly and discussed and planned, as opposed to, oh, by the way, I found out I was pregnant and I've been pregnant 4 months or something of the sorts. So it's really something that should be planned, and that's more likely to work out well for the mother who's a transplant recipient and the baby.
Great question. As far as certain types of supplements, your vitamin supplements, yes, you do need to take those post-transplant, especially the vitamins A, D, E, and K that are fat soluble, that tend to be lower in the body, but you still need to take those supplements. As far as any other type of vitamin or herbal supplements, always please clarify with the team before you start taking any, just so that we can make sure that they don't interact with any of the other medications that you're taking for transplant, especially when it comes to some of the more herbal supplements, just because we need to make sure that they are safe for people to take, but that also that they don't interact in any way with your post-transplant meds. As far as your calorie and your protein supplements go, that's very dependent on how you're doing after transplant. So immediately after transplant, when you're still in the hospital, we do tend to use them just to make sure that you're getting all of the calories and the protein that you need to help your body heal after transplant. But as you progress and you're in the hospital, then we start to see how well you can eat, and then tend to back off some of those supplements too, just to make sure that you can eat as well as you'd like to. And then going home, it's very individualized if you do need to continue to take them, if you're not able to eat well. But sometimes people are able to go home without using them. Sometimes we do send them home. It really just depends on how you're doing.
Thanks, Kate. Our next question, Dr. Hashem, is about being in St. Louis, or the need to be in St. Louis, and specifically, will I need to relocate to St. Louis before my transplant, and how long will I need to live in St. Louis after transplant? And this is something that even Rebecca may want to comment on, because I'm sure that some people may be wondering what the impact of having to temporarily live in St. Louis may be on them and their families.
Well, I don't know why anyone wouldn't want to live in St. Louis. But in all seriousness, in general, patients can stay at home while they wait for transplant, and that's I think a very important plus, because it's a difficult time. They're dealing with advanced lung disease, and they need to have a support person. So doing that at home is obviously much more preferable. In certain circumstances, depending on the clinical course, if someone's getting sick very frequently, getting hospitalized very frequently, and is really having a difficult time, we may have them move to St. Louis and be closer to the program, where we can see them more frequently and potentially keep them out of the hospital and keep them healthier as they wait for transplant. But I think that those are rare circumstances. At the time of the transplant, we really need patients to make it into the hospital within about 6 hours or so. And I think for the CF centers that are represented in tonight's town hall, that really captures everybody. Unless someone lived quite a bit of distance away from the CF center in a further direction from St. Louis, I think for most patients, they'd be able to stay at home and drive in the day of the transplant to have the transplant. In the period after the transplant, we ask patients to stay in St. Louis for 3 months from the time of the transplant. So the first 3 weeks are generally in the hospital, and then there's the remainder of the 3 months while they're in St. Louis. That early period of time, there's a lot of potential problems that can come up related to medications. We're checking blood work twice a week to adjust medication doses. We're doing bronchoscopy to take lung biopsies, look for episodes of rejection. Frequently in those 3 months, we're doing pulmonary rehab as an outpatient every day of the work week. And so there's a lot going on in that 3-month period. But in general, when patients get to that 3-month time point, they really feel much better than they did before the transplant, and in many circumstances, much better than they did years ago. And so they're really prepared to go home. And at that point, there's a bit of a transition as we work out a plan of how do we follow you when you return home, and how do we communicate with your CF center, and who are you going to see, where are you going to get blood work and other tests, and so on. But that's generally a transition that works out very well, particularly with the CF centers that are represented today because of our long history of working together. Rebecca, you may want to comment on the stay in St. Louis.
I do, and I'm kind of chuckling, and you guys will laugh with me also, but I learned today that the St. Louis Recreational Vehicle Park is closing. And I know that sounds funny, but they have let our patients stay there with campers and trailers for years. And the reason I mentioned that is we have a variety of housing options for families. And the reason for that is we know that many people come from a lot of different financial backgrounds and different family makeups and different needs. And we really try to not cookie cut what we expect you to be doing as far as where you're living, but to tailor the options so that they fit what those patients and families need. And we've seen some changes recently with local shuttle programs because of COVID, but we're trying to work around those. So if you have questions about that, please talk to your CF social worker. We have a lot of ongoing dialogue about what some of those options might be. But believe me, I have a lot of tricks up my sleeve to address housing.
Thanks, Rebecca. Um, so, Dr. Hashem, our final question, kind of in this group of questions, if you will, is one for you, and it's really a two-part question. And so, the question is, what data is available specific to the outcomes in CF patients? And then the second piece of the question is, are there long-term complications that may be specific to CF patients?
It's a very good question. In general, individuals with CF have better outcomes than all other diagnostic groups after lung transplantation. The average survival internationally for people that have CF is approximately 10 years after lung transplantation. In contrast, the average survival for all comers internationally is about 6 years. And so that's on average 4 years better for people with CF than it is for all comers who have a lung transplant. The CF specific problems tend to occur early after transplant, but also in some situations are lifelong problems that require attention. You'll have new lungs that don't have CF, but you still have your CF pancreas, you still have your CF sinuses, you still have your CF intestinal tract. And so those other parts that are affected by CF will remain with you and will remain affected by CF. On the other hand, the lungs, which were the main acute problem, have been transplanted and are doing very well. And so there are problems related to infections that tend to happen, particularly in the early period after transplant, although respiratory infections with bacteria can occur at any time point. The sinuses are a reservoir for infections, bacterial infections in particular, and those bacteria can find their way into the transplanted lungs. And so although the transplanted lungs no longer have, or you no longer have CF in your lungs, and the transplanted lungs are not from someone with CF, Pseudomonas or MRSA may find its way into the transplanted lungs and cause an infection in the transplanted lungs. CF-related diabetes will persist. It may be exacerbated by the medications that are necessary after transplant. Needing enzymes will remain necessary after transplant. Now, diet may change, weight may change, and the enzyme dose might need to be adjusted. The GI tract is also affected by CF in many individuals. There's a higher risk of colon polyps in individuals with CF, and that risk seems to be increased among those who've had a transplant. And so consequently, there's a higher risk of colon cancer in individuals with CF, particularly after transplant. And so it's recommended that individuals with CF who've had a transplant have a screening colonoscopy at an earlier age, at the age of 30, as opposed to the general public who has a screening colonoscopy at the age of 50. So those are some of the CF-related issues that come up after transplant and require attention that's unique to individuals with CF as opposed to other diagnostic categories.
Thanks, Dr. Hashem. Before we move on to our next series of questions, I did just want to remind everybody that if you thought of any questions during the course of this evening's discussion, you can feel free to submit those questions and we will try and get them answered for you. So our final group of questions, if you will, are a bit more general, just in the sense that they're questions that really apply kind of throughout the entire transplant process. And so our first question is one for Rebecca, and the question is, what is the role of the caregiver during the transplant and recovery?
Thanks, Greg. Many of you living with a chronic illness have relationships, and you notice that as you become sicker or have an exacerbation, that sometimes those relationships with your family or your friends change, and you go from being husband and wife to patient and caregiver, or child and adult to patient and caregiver. And it's important for you in those times and in moving forward with transplant to be thinking about what that caregiver needs to do for you and what that caregiver does not need to do for you. Specifically with transplant, we do require that a caregiver, in addition to the evaluation, be available to you 24 hours a day, 7 days a week for 3 months after your transplant. And that person is really your second set of eyes and ears. They're learning your medications. They're learning all those great dietary messages that Kate is sharing. They're talking about your physical limitations that Dr. Hashem has mentioned. Not only what you can pick up and carry, but also your driving privileges are going to be suspended. So they're going to be bringing you back and forth to appointments and to rehab and to all the other errands that you'll need to do in the St. Louis area. They're going to be learning when to adjust medicines when the coordinator calls and says, cut back on your Prograf, we got your labs back. But they're also going to be there to kind of pick you up and put you through and he'll help build you up after this surgery. This is a very traumatic event, and having somebody there that you know is going to support you through that is key. And we will help you explore who that might be. And sometimes that might be 1 or 2 people, or that might be somebody that you haven't thought of that could step into that role. But we always want to make sure that that caregiver is taken care of themselves, that they're doing their own self-care. They're not financially in jeopardy because they've stopped working, and other people that they care for at home are not being neglected or not having their needs met because this caregiver is coming with you. So it's an ongoing conversation that we continue to change and address based on your needs and the timing of your transplant.
Thanks, Rebecca. Our next question is one for you as well, and it's on the topic of a support person. And the question is, do I need a support person for the entire transplant process?
So yes, for the most part. But a lot of times we will see patients get called in for transplant, have their surgery, start to recover and work with physical therapy. And there's a little bit of a gap where sometimes caregivers need to maybe run home and get more clothes, or the seasons changed and now they don't have enough sweaters. So while that patient is in the hospital, there is a little bit of a gap where we can do some trading off and let those caregivers run home and tend to needs. But starting on that day of discharge, even a day or 2 before, for teaching purposes, they do have to have somebody with them at all times.
Thanks, Rebecca. Our next question is one, for Dr. Hashem, and we've talked a little bit about COVID and certainly, the impact of COVID on hospital operations and visitor policies. But this question is about the precautions that we have taken in the outpatient environment in terms of the coming to see the doctor and appointments.
Yeah, that's a good question. I'm sure that all hospitals have taken a lot of precautions to minimize exposure of patients and staff to COVID. First, all physicians and staff are screened for COVID every morning when we come to work, and we answer a questionnaire about symptoms, and our temperature is checked, and then we're allowed to come into work. Obviously, if there's a potential exposure or potential symptom that's consistent with COVID, we're funneled to occupational health to see if that person ought to be tested, if they should not return to work, and so on. So we can pick out individuals who are coming to work who may have symptoms of COVID or may have an exposure, et cetera, and work through occupational health to make sure that those individuals who may have an infection are not being exposed to patients. Then patients and their family members are screened for potential symptoms of COVID the day before a visit and then the day of the visit, and everyone has their temperature checked when they arrive for a visit. Also, everybody, both on the physician and staff side and patients and family members, wear masks. So everybody has a mask on. and is asked to keep their mask on throughout their visit to the medical center. And for those of us that work here, we have our masks on all day, unless we're in a private office, as I am right now, and there's no one around me. But otherwise, everybody has a mask on to minimize the risk of spreading COVID.
Thanks, Dr. Hashem. Our next question is another one for you, Rebecca. And the question asks if we have a support group available, but perhaps, as you respond to that question, you could also touch on our mentor program a little bit.
Absolutely. For many, many years, we have had a very active mentor program at Barnes-Jewish Hospital. We've had a collection of post-transplant patients, cystic fibrosis, pulmonary fibrosis, all diseases that have the dedication to give back to our program. So at 6 months after our transplant, we identify the people that are interested in becoming trained as mentors, and they do a variety of volunteer opportunities at our hospital. Richard mans the desk in one of the waiting rooms. We've had our mentors prior to COVID meet with patients talking about their experience of having a transplant. We call that our Monday mentor meeting. Beth and I started just into COVID, or just before COVID, our Navigator program, which we are kind of modeling after Siteman Cancer Services, to have mentors available to help you navigate those 7 a.m. Monday appointments and where to go and who to check in with. And fortunately, it was a huge success. Unfortunately, we had to stop it very soon because of the risk. So we do have a very active program. We obviously do not have one-on-one physical contact between patients with cystic fibrosis. So sometimes just sitting down with another patient with a different disease, but hearing what they've been through can be a benefit. And then we'll follow up with a phone call or an email later on so that you can talk to somebody who's had cystic fibrosis and what their experience has been like. So we do have a lot of support. They do a lot of telephone work. They do a lot of FaceTime with people that are coming for the evaluation.
Thanks, Rebecca. So that brings us to what looks to be our final question of the evening. And this is one that I think you will probably want to weigh in on, Dr. Hashem, but it's food related. So Kate may want to respond too. But the question is about edible marijuana and whether or not it's safe to consume edible marijuana either before or after transplant.
I'm going to let Ramsey or Dr. Hashem take that one.
I was going to suggest that since it starts with edibles, that is best addressed by a dietitian. But what do I know? In seriousness, we discourage the use of all marijuana products, edible or smoking marijuana. And the rationale behind that is multifold. One, that tends to be an indication that there are some mental health issues or problems that are not well addressed. And rather than address these with substances, I think we're going to get much farther by addressing the underlying problem or mental health issue that is leading to potential use of edibles or smoking marijuana. And that, I think, will be a much better lasting approach to the problem rather than covering it with use of edibles. The other issue is in many circumstances, we don't really know what is in there. These are not well-regulated foods here, and other substances that might be included might be harmful and might have interactions with medications. And certainly smoking is a bad idea for someone who's had a lung transplant, particularly because marijuana smoking can also have aspergillus fungus that's aerosolized and can get into the transplanted lungs. And so there's a number of health reasons that we discourage the use of all marijuana products, from smoking to use of edibles. But obviously, Kate, Rebecca, and Beth, please weigh in if there are other parts that I've not discussed.
Kate, I see the wheels turning.
I think you covered it, Dr. Hashem.
Agreed.
Well, I'm going to add just a couple comments. And not only is it marijuana, it's vaping, it's lots of different substances, because Dr. Hashem's right. We really need to get to kind of what the root of the issue is. Because again, as I said earlier, transplant is a traumatic event. And going into it with good, healthy coping skills is really, really key in your recovery. So we will dig into that a little bit when you come for an evaluation.
All right. Well, thank you, everyone. As I mentioned, that was our final question. So as we I just wrap things up here for this evening, I thought I'd start by seeing if any of our panelists have any final thoughts or comments that they wanted to share.
I would just like to thank you all for joining us this evening. We're very happy to host this, and we hope you found this very beneficial. So please don't hesitate to reach out to your CF team if you think of any other questions, and they know how to get a hold of us.
Definitely. Thank you all for attending, and thank the team for being here and answering the questions, and Greg for moderating. I think this was terrific.
Well, thank you. So just a couple of quick reminders. I want to first remind everyone that this evening's event has been recorded. So if you want to watch this again, or have a family member who couldn't see the event live but would like to watch it, you can access it using the same link that you used to access this evening's event. And then also just a request that if you would mind, we would really appreciate it if you'd take a few minutes to answer the short survey that we've created to provide us with some feedback on this evening's event. And again, you should see the link to that survey there on the same page where you're watching this evening's event. So with that, on behalf of St. Louis University, the University of Missouri, the University of Tennessee, and Washington University and the Barnes-Jewish Hospital Lung Transplant Program, I'd like to thank you all for joining this evening and hope you have a great night. Thank you, everyone.
Good night, everybody.
Good night.